All right, let's jump right in. Today we're talking about a really important technique used in intensive care called manual hyperinflation. What is it, you ask? Well, you can think of it as the ultimate assisted deep breath for a patient who just can't take one on their own.
So, picture this, a patient in the ICU. They're weak, they're ventilated, and they can't manage a deep, clearing breath. How do you help them do that? That is the exact problem that manual hyperinflation, or MHI for short, was created to solve.
You know, when you really boil it down, the concept is beautifully simple. It's basically like giving that patient a manual sigh or even an assisted cough. It's all about mimicking those natural, crucial lung functions that their body just can't pull off at the moment.
Okay, let's get a little more specific. What's actually happening here? A caregiver uses a manual resuscitator. You've probably seen one. It's often called an ambu bag, to give these slow, deep, and really controlled breaths. But it's not just about pushing air in. There's a very deliberate pause after the breath goes in, followed by a super quick release. That specific rhythm, well, that's the secret sauce that makes it all work.
So that's the big idea we're working with here. At its heart, MHI is an assisted deep breath. Now that we've got a handle on what it is, let's dive into why it's actually used.
So, why is this so necessary? What are the specific goals? What is a therapist or a nurse trying to achieve when they perform MHI?
It really breaks down into four main objectives. First, and this is a big one, mobilizing secretions. You're trying to move all that sticky mucus from the tiny little airways up into the bigger ones where it can be suctioned out. Second is what's called lung recruitment. Think of it like popping open all the tiny little air sacs, the alveoli, that have deflated and collapsed. That leads directly to the third goal, reversing atelectasis, which is just the medical term for those collapsed lung areas. And finally, when you do all that, the payoff is improved gas exchange. The patient can get more oxygen into their blood. It all works together.
So at the end of the day, MHI is all about hitting a manual reset button for the lungs. You're trying to restore normal lung mechanics when the patient's body is just too compromised to do the job itself.
Okay, we know the why. Now let's get into the how. How is this procedure actually done? It all comes down to a very specific three-part technique. First things first, you need the right gear. The star of the show is the manual resuscitation bag, of course, hooked up to an oxygen supply. But a really key piece of safety equipment is a pressure manometer. It's highly recommended because it makes sure the caregiver doesn't accidentally overinflate the lungs. And of course, you have to have suction equipment standing by and ready to go to clear out anything that gets moved up.
The whole technique is built around this three-part rhythm. Step 1, a slow squeeze of the bag, we're talking 1 to 3 seconds, to let that air spread out nice and evenly through the lungs. Step 2, an inspiratory hold. You pause for just a second or two to give that air a chance to sneak into all those collapsed areas. And step 3, this is the magic part, a rapid release. You let go suddenly, which creates this rush of air flowing out, and that's what mimics a cough and helps push all that mucus up and out.
And this isn't just a one-and-done kind of thing. A typical treatment involves repeating that slow squeeze, hold, and rapid release cycle about 6 to 10 times. After that, you stop, reassess the patient, and see how they're responding.
Now, here's the thing. With any medical procedure this powerful, you absolutely have to talk about the risks. It's a delicate balancing act, and it's critical for caregivers to weigh the potential benefits against some pretty significant dangers. And you can really see the two sides of the coin here. On the one hand, the benefits are huge. You're clearing out gunk, making the lungs work better, and boosting oxygen levels. But on the other side, the risks are serious. If it's done wrong, you could cause lung injury from too much pressure. That's called barrel trauma. Or it could mess with the patient's blood pressure, among other complications. Because of those risks, there are some very clear, hard and fast rules about when you should not use MHI. They fall into two camps. You've got your absolute contraindications. That means never do it, like if a patient has a collapsed lung that hasn't been treated. Then you have relative ones, which means, whoa, be extremely careful here. For example, if a patient has broken ribs or really unstable blood pressure. So with all these risks on the table, this brings us to our final and, honestly, most important point. What's the single biggest factor in making sure this powerful tool is used safely and effectively? Well, all the evidence points to one thing, and it's crystal clear: the safety and the success of MHI. It all comes down to the skill and the training of the person performing it. It's all in their hands, literally. So here's the key takeaway. Manual hyperinflation is a potent, hands-on technique that can make a huge difference in a patient's recovery.
But, and this is a big but, it's not a simple procedure. Its power to heal is matched one for one by its potential to cause harm if it isn't done with skill, precision, and care.
And that leaves us with a really interesting question to think about. In our age of super advanced, automated ventilators, what does a technique like this tell us about the irreplaceable value of a skilled clinician's hands? Thanks for digging into this with us.